Hello, good afternoon. Welcome, everyone. My name is Natasha Phillips. I am the founder of an organisation called Future Nurse, which is focused on ensuring the nursing voice is heard loud and proud in the digital arena and supporting nurses to practice and lead in digital healthcare systems. Um, I am today joined by two great, very experienced digital nurse leaders to talk about remote care. It's really interesting to think about how far we've come in such a short period of time. Hospital at home and other models of care and support are not new. They've been around for a long time, but since the pandemic, we've seen the rapid adoption of digitally enabled models of care based at home, enabling us to step into that space with our patients as nurses and make sure that they're safe. These models of care, they really fit with our core purpose as nurses. Our core function is enabling people to live as well and as long as possible, regardless of disability or disease, at home or as close to home as possible. Remote monitoring enables us to do this safely, and we all know that patients do better at home. We have a key role to play in delivering remote care. And today's webinar, we will learn more from those leading and those providing remote enabled care to really think about what's your role, well, how can you do this, how can you get involved, how are we going to take this forward, what are the opportunities, what are the challenges. So I'm going to go to, without further ado, to introduce my two speakers. But before I do that, I just want to say a big thank you to Doccla, who have sponsored this webinar today. Thank you very much, Doccla, for making the time and space for us as a group of nurses to have this vitally important professional discussion. So our first speaker today is Gordon Elder. And Gordon is a CNIO and an Assistant Director of Nursing at Newcastle Hospitals. He's also, as if that wasn't a big enough job, the Regional CNIO for North Eastern Yorkshire. And I guess Gordon's unique expertise here is that he has led many successful programmes of digital enabled change, not least the Nightingale Hospital in the North East during the pandemic. Gordon today is going to give us an overview of virtual wards, talking specifically about the technologies, the fit of those with models of care, and look to our future, thinking really carefully about digital inclusion. As nurse advocates, that's one of our key roles. Thank you so much, Gordon, for joining us today. Before we move over to hear your insights, I'm also going to introduce Rebecca Ashworth, who's lead nurse for clinical engagement and the clinical safety officer at Doccla. She's a really experienced emergency department, acute, community care and research nurse. What a collection of skills she's got to bring to this job. And she joined Doccla in 2021, where she has played a vital role in shaping their virtual ward service to ensure safe, high quality remote monitoring services for patients. And what Becky's going to do in the second half of this webinar is giving us an insight into the day-to-day work of remote monitoring nurses and the skills needed for that role and how one builds a team to ensure that you have the right knowledge and skills available to deliver this model of care. A couple of key housekeeping bits that I want to draw your attention to before I hand over to Gordon is the ability for you to join the conversation. We really want to make sure that we have time for robust conversation. So the running order today is that Gordon will speak for approximately 20 minutes, perhaps a little bit more, from about the issues that I've told you he's going to speak to. And then Rebecca will do the same. Keep putting your questions in the chat. If you're anything like me, you don't want to save them to the end because you will worry that you will lose them from your head. We've got a group moderating the chat. So if you keep popping them in there, we'll then extract those and make sure that we have plenty of time after our two key speakers, probably about half an hour, for a good group discussion on the topic. If you particularly like someone else's question, please do give it the thumbs up sign so we can see the areas of conversation that people most want to follow throughout this next hour and a half that we've got together. But without further ado, I'm going to hand over to Gordon. Gordon, really excited to hear what you have to say. Over to you.
Thanks, Natasha. It's great to be here, and hello to everybody this afternoon. So I'll start by sharing. Okay, so as Natasha said, I'm Gordon Elder. I have two roles, Regional CNIO and Associate Director of Nursing and CNI for Newcastle Hospitals. Today, I'd like to talk to you about virtual wards and give you a brief overview in the areas that we've learned from the North East and Yorkshire and across the country. And of course, the key role that nurses will play. We'll go through a little bit about what the technologies that are available and how that can enhance patient care and patient safety, but also looking at digital inclusion, making sure that we don't exclude any of our patients. And as Natasha says, you know, the outcome for patients who go home are great, and patients really like it. It enhances the patient experience. So let's start. So the first thing is definitions from virtual wards, which came from NHS England in relation to what we're looking for. And it's preventing avoidable admissions, but also to allow patients to go home earlier and recover at home safely. These are the key aspects of what you want to do. And I would always be the first, if it was me who was on a ward, I'd want to go home and I want to look at in my own environment, eating my own food with my own family and doing everything that's normal as opposed to being on a ward. So we can't underestimate the power that that has for our patients. And also we've learned so much during COVID, and the feedback that we've got from our patients was they felt really safe. And it's really important to understand that as nurses about that well-being and that safety that our patients have. In relation to technology enablement, there are three aspects of that which enhance a virtual ward. The first one is for the ability for the patients to be able to enter data quickly, safely, and very intuitively. No point in giving complex systems that they have to enter various things at various times. Simple apps that give them simple instructions, or connecting via Bluetooth from a SpO2 monitor, SPEG, thermometer, where that data is automatically uploaded and looking at their vital signs over a period of time. The second part of the technology enablement is in relation to the digital platform. That allows clinical staff to log in. It allows them to look at the trends and get that whole clinical picture in relation to what we're doing for our patients and make sure they're safe. And the third aspect of technology enablement is an alerting system. So if that patient hasn't entered their data, making sure that staff are aware of that, and that it's usually nurses that are monitoring this 24 hours a day, and also helping us to prioritize. So if the patient's SpO2 goes out of a normal parameter, how do we make sure that that's highlighted to the clinical teams so they can deal with that? So if someone's SpO2 drops below their specific target of 95, that needs to be alerted, so those patients need to be dealt with first. So those are the three aspects of the definitions. But why is virtual wards important? Well, there's loads of things in it, and Natasha's already alluded to that, is that it's what patients want. During COVID, we had thousands of patients who stayed at home, and the feedback afterwards in a lot of our hospitals from patients was they felt safe, they felt secure, and they didn't feel the need to go to A&E or a GP practice. They just needed someone who they could talk to if they were worried and to get advice from, and that was made available. So to expand that further, we're looking at multi-specialties and multi-clinical pathways in relation to getting patients home. And we'll discuss some of that in a little bit. But patient safety has to be at our forefront, and we have to ensure that whenever we send our patients home, that they are safe and they feel safe. That's really important. Scalability from a technology point of view is really important as well. So if you have small numbers, 20 to 30, then that could be dealt with manually. But as you start to get over those numbers, technology becomes much more important because it will help you prioritize patients who require your attention quickly or first, so to help to prioritize the workload as your day is progressing for all clinical staff. It can help improve self-care for patients, empower patients and give them a better sense of well-being. It's time saved through accessing services digitally, so actually it can be much more convenient for patients. And cost saved through access. And so be under no illusion, cost is one of the things that we have to consider. The ability to get patients home more quickly, which will make them happy. It would make me happy. And I think that making sure that they feel safe. And also reduced length of stay and increased capacity of more beds. So we all know as nurses that patients being on a hospital ward for a longer period of time are at risk of hospital-acquired infections, DVTs, respiratory infections, various things that are complications of being in on a ward. So if we can reduce those, then I think that's really important. And of course, for the overall health care system, cost of delivering services digitally can be more cost effective and better adherence to medications and treatments as well for our patients. The clinical model varies significantly depending on which specialty you're looking at, whether it's a specialty agnostic service, so that would take surgery, medicine, cardiovascular, any other path, and looking at fitting the virtual ward around that, or having very specialty specific pathways like frailty or respiratory or heart failure. There's multiple things that we can do to help our patients, and each one, and this is the key, has to be tailored right down to that individual patient needs. Each patient will require something different. They'll require different clinical support. They will require different times to do their observations, different observations, and that will reduce over time, hopefully. So we have to make sure from a medical model we can fit all of those patients in there. From a patient suitability point of view, there's lots of things. Patients may not feel comfortable about going home. They may feel more comfortable being on a ward and being there, and that has to be taken into consideration. And also, who is at home with that patient? Who's going to help them and support them? The patient experience, is that something that they want to do? Is it something they feel passionate about, they'd like to get home? And their overall well-being all need to be considered at the time when looking at virtual wards and patient suitability for that. There's lots of social situations in relation to virtual wards that we must be really cognizant of. And that's just not about someone being at home and a carer to help that patient when they're at home, or to raise an alert if something goes wrong. But we also have to consider the financial situation of the country at the minute. And sometimes, sadly, patients would prefer to stay in hospital because it's cheaper for them. They don't have to heat their homes. They don't have to feed themselves. They can get that. So social situations need to be considered from a virtual ward point of view, and any assistance and any grants or whatever that we can provide for patients must be taken into consideration at this time. As clinical staff and as nurses, we can be quite parental, and we like to think about, sometimes we think we want to do the best for our patients. We always do. But sending them home when normally they'd have been for a week or normally been for 5 days can feel a bit uncomfortable for us. And it takes time for that clinical confidence to grow, not just in nursing, but in medicine and all other AHPs as well. And we've found that across multiple virtual wards, is that clinical confidence needs to grow over a period of time. I've already mentioned patient safety has to be at the forefront. Patient needs to be able to access clinical staff 24 hours a day. We need to be able to monitor them either remotely via inputting data into a device or continuous monitoring. There's various things, and we'll discuss devices that are coming up shortly. And then also the things to consider: practicality about getting medications and virtual consultations, and sometimes a home visit. If you need a blood done on a patient, sometimes we need to do that while they're on a virtual ward. All of that logistics has to be carried out. And of course, really importantly, and very few, thankfully, but there has to be a readmission pathway quickly for that patient if they deteriorate while they're at home. The last little icon there is a link to the NHS England guide on virtual wards, which has videos and lots of information. I'm happy to share these slides afterwards. So how does it work? Well, recording in virtual wards from a patient point of view, they're given devices, and they take those home, and then they enter the data either via web portal or via a tablet or a smartphone that is usually supplied, but they can use their own depending on which service or which platform they're using. They enter the data at specific times that we tell them to. So usually be 4 times a day, then it might go to 3, then 2, then once a day, then potentially none. And then we ask the patient to also fill in questionnaires. And this is where nurses come into the fore. There's nothing more powerful than asking a patient, how are you feeling today? Do you feel a bit better or do you feel a bit worse? But of course, it's also really important to carry on with the continuous nursing holistic care. Is that patient thriving? Are they doing well? Are they mobilizing? Are they eating? What is their mental health like? All of the things as nurses we do quite naturally on a ward, we need to carry on within a virtual ward. There's lots of systems that can be used, but they need to have some criteria to ensure that we make sure that they work correctly and that they're the best thing for the patient and for the clinical staff that's using them. So vital sign entry and being able to look at trends and analysis, questionnaires, just as I've said before, making sure that the patient's feeling well and progressing well, but also specifically around their current condition and whatever pathway they're on. How we prioritize information, how we prioritize our patients when we come in to have a look at these. And if you've got 150, 200 patients, the system needs to be able to help and look and prioritize that. Configurable alerting. So again, there's no point in giving a COPD patient a SpO2 target of 95, 96, or 97. That's not going to be reasonable. They're going to alert all of the time. But if their normal running SpO2 is 90, 92, 93, that could be the target. Integrating and sharing information, really important with GP practices and other acute trusts and the teams involved, and making sure they all have access. Clinical recording and video conferencing also really important about how do we get that information back into the patient's record and making sure that we're sharing it with all the relevant people. So those are all the things about the platform. Lots of devices that we can use, from continuous monitoring, but the basic kit is normally a SPHIG, thermometer, pulse oximeter, scales, and questionnaires. But we can also look at patient-specific kit. And we can look at lots of different types. On the bottom left there, you can see that's a particular device, just a standardized device package that we would send to a patient's home. That would be retrieved back, cleaned, and then sent out to the next patient when need be. But we can have portable ECGs, which give 6-lead ECGs, and are really useful. We use those for lots of remote monitoring programs. But we need to think about how many do we need. If you've got 40 beds, you probably need at least 80 sets of devices, because they need to come back from a patient, be cleaned, and then sent back out again. How do we get them to patients? How do we clean them? What do we clean them with? What happens when they break? When do they need calibrated? And then staff training, of course. All of these things are considerations from a virtual ward point of view. Some issues with tech enablement, that there's multiple solutions that are available out there, and sometimes it can be difficult to choose which one suits your specific service. But also within an acute trust, you also think there's multiple services using the same system. The system must be able to be compatible with all of those clinical pathways. Devices that are available, we need to make sure they're kite marked and they're DTAC approved, so we know that they're safe for patients to use and they're accurate. We need to ensure that clinical assurance and skills are kept up to date. Anybody who does a virtual ward, it's not the same as standing beside a bed in a hospital. So those skills required need training for our clinical staff, that when you're doing a virtual consultation, that you need to understand all of the things that are going on with that patient, and helping our clinical staff to make that proper assessment. As nurses, we know our assessment starts the second we set our eyes on a patient. So doing it virtually requires some different skills. Interoperability and sharing, really important. How do we get that information to GP when we discharge that patient from a virtual ward onto into primary care or into community? So there's lots of things we have to consider with that. Resolution of problems. When there is a problem with IT, how do we fix that? Because it'll usually be 2 o'clock on a Sunday morning when there's a problem. How do we make sure have that? And then clinical expectations about what the system should be able to do needs to be managed, to make sure that we understand that it's not Star Trek and we can't do everything that we can on a virtual ward, but we can do lots, and there's lots of things that will continue to progress as technology goes. And making sure we provide not only the education to our patients, but all the information that they need. So simple, easy video guides, very quick handheld guides, whatever that patient needs for that time is really, really important. But what are the problems and how do we make sure? So we know that the benefits of virtual wards for patients, the patients want to do this, but there's lots of things that can stop patients from doing this, and we need to be very, very conscious of that as nurses. Connectivity. So we do know that 4.8 million people in this country never go online. They absolutely never ever go online at all or access the internet. We also know that 90% of households have broadband, which means that 10% don't. How do we make sure we don't exclude any of our patients from virtual wards and the benefits just because they can't get online or they don't know how to? Some patients don't have the digital skills or don't have the inclination that they want to go online because they're worried and they have fears about going online. So how do we make sure that we link in local groups and communities like Citizens Online and local volunteer groups to help patients? Because the benefits from going online can be beyond healthcare, so patients can benefit from a lot more. Confidence, they fear crime, rightfully so. They lack trust and don't know where to start. We need to be able to make sure we point patients in the right direction. We provide them with everything that they need from a virtual ward point of view, because we don't want them to be excluded from that. We want them to be included to enjoy the benefits of virtual ward if that's what they want to do. Motivation, some patients just won't want to do it. Well, that's okay. That's absolutely fine. Some patients this is not suitable for, and we need to carry on with what we do now. Design is something that's really important to me. Friendly user interfaces is the key to making sure patients can understand. There's no point in giving someone a tablet computer with 56 different applications on it. That's not what it's about. It's about simple, straightforward, intuitive interfaces that patients can use, and then they'll want to use it. Awareness, how do we get patients more digitally aware whenever they don't go online? How do we make sure the patients are not frightened of this? And to me, nurses are some of the keys to do that, because we know our patients. We build long-term relationships with lots of our patients, and we know that what their needs can be, and nurses are in a perfect spot to be able to identify the needs of each patient. But we can't do that without staff capability and capacity. If our staff don't understand how to use the technology, how will they ever be able to tell patients or explain to patients? And if we don't give staff and clinical staff the time to spend with patients, of course, nothing's going to happen. So therefore, there's a couple of things that we need to think about. And one of the things that we need to do is look at a pick and mix solution. And how do we make sure that our patients are getting the right digital platforms, the right virtual wards at a time when they need it and when they want it? But there could be multiple solutions for that. So let me give you an example. Of course, as I'm sure you would expect, I'm very digitally savvy. I want all of my consultation letters to come electronically. I want my appointments to go directly into my calendar. I want to be reminded before that. I want GPS to tell me how to get there, where to park. I want all of that. However, if I'd been referred in for a 2-week cancer pathway wait, and I can tell you, I would want to be in that hospital. I would want to be in front of my consultant and my specialist nurse to ask them questions. I wouldn't want that virtually. I wouldn't want to do anything like that virtually. So we have to understand not only where our patients are at, but where they're at on their clinical journey. It's really, really important that we think about our patients at the time where they're at. And it could well be that, once patients are over a certain part of their clinical journey, they're very happy to have virtual consultations, go onto a virtual ward, and then long-term condition management. So there's lots of things that we need to consider in relation to that, and making sure we offer a pick and mix solution. And the other thing that we have to ensure that we don't do is that we don't discard older technologies. So text messaging has proved to be very effective. This can be a good way to communicate with patients. And in some areas, patients text back their blood pressure, their temperature, just simple text, 37.4, and send it back. And that's how it's recorded. So we need to make sure that the technology solutions we offer are absolutely there to meet our patients' needs. And again, I strongly believe that nurses are in the key position to do that. The last slide that I'm going to leave you with is in relation to from NHS Digital. And it's a concerning aspect in relation as technology goes forward as a whole, not just from a virtual wards point of view. But we need to make sure that we increase our knowledge and our skills of our staff around digital enablement. We need to ensure that our future nurses coming through have good digital technology education and support, because if we don't, our patients could end up seeing where health inequalities become even greater over a period of time, and we exclude people who would significantly benefit from digital enablement. The costs of traveling to and from a hospital can be greatly reduced if you don't need. And I'm going to give you another example today. I had an appointment on Monday for a long-term condition that I had, and I was in the department for 1 hour and 45 minutes. I spent about 30 seconds with the consultant because everything was fine, nothing has changed, and I was told I'll see you in a year. But that was 1 hour and 45 minutes out of my day. And I can imagine if patients, they can't afford to park, they find it difficult, or they lack that engagement. So in that scenario, technology could be great, but we need to be careful that we don't exclude patients from that. We need to offer a pick and mix solution. We need to make sure that we continue to make all services the equity of access and making sure we meet the needs of our patients. Thank you.
Gordon, thank you ever so much. And I know that questions are coming in thick and fast in the chat. Please do keep them coming in. I'm desperate to jump into the chat. There's some great questions there, but I'm going to hang fire. And I think it'll be really useful now to switch over and hear from Becky from that very practical, what it's really like to do this. I think we've had a fantastic overview, but I'm looking for some insights, Becca, on what it's really like to do this work and what patients really say about experiencing this type of care. So looking forward to it. Over to you.
Thank you very much. Let me share my screen. Okay. So yeah, thanks so much for that introduction, Natasha, and also thank you, Nursing Times, for having me as well. So as Natasha said, I'm lead nurse for clinical engagement and I am clinical safety officer. And this presentation is just going to give a short overview, predominantly of sort of the learnings that we've had over the last couple of years of building a remote monitoring team for tech-enabled wards. As Gordon and Natasha have said, the virtual ward idea has been around for quite a long time, but tech-enabled has really taken off after the COVID pandemic. So we've got some key learnings in here, and I really hope that I can pass some of those on to yourselves. So in this presentation, I'll have a look at what is the remote monitoring nurse. I'll look at a day in the life of what does being a remote monitoring nurse look like on the ground. Some of the challenges that we found. I'll also have a look into some of the role essentials and the desirables, and then specifically the clinical competencies. Because this is a new role, it's very much we're learning as we go along. So I think it's going to be a really good opportunity to pass on some of the learnings that we've had. And then finally, I'll finish on what are the workforce benefits that remote monitoring offers. So I want to say that I'm a nurse first and foremost, and I'm here very much as a nurse, but I will give a brief overview of what Doccla does. And this is just to give you an idea of where my experience comes from. But I really do hope that the information that I give is relevant to everyone, regardless of what provider our nurses are using. So Doccla provide an end-to-end service for virtual wards. In brief, this covers monitoring devices and logistics. We are device agnostic, so we scour the market. We use the best devices that we can find. We take responsibility for decontamination, etc. And this means that if you're a patient on the service, Doccla will send a kit out to that patient, and inside that kit will be the devices that's relevant for their pathway. And then there'll also be a pre-configured, it's usually a mobile phone, but can be a tablet. On that pre-configured mobile phone is an app, and this is where the patient uses the devices provided to enter their readings onto the app. They then click send, and this goes through to the clinician web portal. As a clinician, I would log on to that web portal, and then I'll be able to assess the readings that have been sent through and make my clinical decisions. And then finally, the clinical capacity. So one of the barriers we found to setting up scaling virtual wards, was that there just isn't always the resources available, especially if recruitment can take a couple of months. So Doccla decided to become CQC registered, and we now have an amazing team of clinical monitoring nurses where we either support our clients to monitor their patients or monitor on behalf of. So let's start with looking at what the remote monitoring nurse does. So What do they do? The technology that we've discussed, they use that technology to monitor patients specifically outside of the hospital setting. So the goal is that we can either support patients to discharge early, or we can avoid that admission, avoid a hospital admission, sorry. Where do they do it? So we have a team of nurses who are dotted all over. We've got a nurse in Edinburgh, we've got nurses in the north of England. I'm based down in London. And yet we've got patients all over the country. So it could be that I'm monitoring patients up in Manchester or Hertfordshire, etc. And then how we do that, I just want to go back to that point, sorry. So although remote monitoring nurses will be monitoring autonomously, they're always part of a wider clinical team. And I'll talk a bit more about that. I think it's on the next slide as how that day looks. And how we do it, so you can see on the right there, that's a demo version of our News 2 dashboard. So we can do News 2, we can also do other vital signs where it doesn't make up the News 2 score, but you can see there that the technology allows prioritization of the patients that come through. So the tech supports the nurse to prioritize their workload. So a day in the life of, at the moment, we don't provide 24/7 monitoring, although I very much think that that will change in the next couple of years. At the moment, we do 12-hour shifts, 8 till 8. It did start 9 to 5, Monday to Friday, but as remote monitoring becomes more popular, it's inevitable that we're going to be increasing our hours. So patients usually submit their readings first thing at 8 o'clock. This is very much pathway dependent. So I've based this on a pathway where they submit 4 times a day, but that's not always the case at all. But generally speaking, patients submit early-ish in the morning. And at the same time, there's a morning huddle like you would have on a ward round. And then a shift lead will allocate the patient groups to clinicians. The morning set of readings, typically, I will say, tends to be a more busier time, just because patients are either they've just got up and had a shower and run around, or they are still very sleepy. So morning times tends to be a bit busier. There's usually an MDT dotted around some point in the day. I've put it at 11 o'clock today. And this particularly for us is important because we will be monitoring either on behalf of or with our clients. So it's really important that we keep in touch with them just to let them know how their patients are doing. But if this was a local service, it would still be important to liaise with the MDT, and that will be an opportunity to escalate concerns, or remote monitoring is usually a nurse-led service. So that's an opportunity to ask for any medication changes, etc., that might need to be made. Midday, there'll be a second set of readings. Usually these go a bit more smoother. So then there's time in the afternoon for additional projects. At Doccla, we have clinicians involved in all parts of the company, really, just mainly because we want to make a service that's made for patients and clinicians. So we have tech liaison roles. We also have clinicians involved in patient information. And then we have user testing as well. A third set of readings will be around 4 o'clock. And then at Doccla, we like to do an afternoon safety huddle. Sometimes this is very much just a 15-minute chinwag. Sometimes it is they have concerns and the team want to bounce ideas off each other, but it just helps maintain that team feeling, even though we're all remote. And then finally, there'll be a last set of readings at around 7. The way that I've worded that is the ideal day in remote monitoring, but we all know as clinicians that days very rarely go quite so smoothly. So if you think that we're monitoring patients that would usually be in acute hospital, it's very likely that we're going to have patients who do require further investigation or escalating. I've had patients where I've had to call 999, so I've had to do an emergency response. And it might also be depending on the resources that you have available in your area, that you might be liaising with community teams and asking them to go and do face-to-face visits if you need to do point of care tests, etc. Just like you would be caring for any patients, there can be safeguarding concerns and you still need to escalate them as you normally would. So the days can be quite busy and quite challenging. At the Doccla remote monitoring team, we have a team of nurses. There's a lot of information on the side, so I'll try and not go into all of it, but I will be showing the slides afterwards. So we have a team of clinicians with experience ranging from 3 years to over 30 years. And we have an age range of early 20s to in the 50s. The backgrounds that we have vary from crit care to ED. We've got community, we've also got specialist nurses, and we have advanced nurse practitioner as well. In terms of the pathways that we monitor, we have a lot, in the tens of pathways, I think certainly over 40. And it's also possible that you could be managing patients that cross over more than one pathway, because we obviously care for patients with comorbidities as well. So we monitor both acute and chronic. We do have specialist roles such as respiratory and paediatrics, and there is options for frailty and cardiac as well. Just as we grow, those specialities will absolutely come along. We are lucky enough to be a big enough team now that we now require a structured team. So there is opportunities there for managerial positions. And then on the side of it, we also have our own research nurse, which has been really important for collecting data to see how the service is doing. And we do that for both ourselves as well as our clients, just to make sure that the virtual ward service is meeting the patient's needs and is efficient as possible. Whenever tech, this was a new role to myself when I came to Doccla, but there's always going to be a clinical safety officer involved in virtual wards, because we're going to be using technology to deliver health. So therefore there has to be adherence to what's called the DCB guidelines, and that all falls under the CSO role. We also have in-house GPs and consultant support as well for any new pathways that come along, just to make sure we're covering everything. So what are the challenges to building our remote monitoring team? What have we found? So we know that virtual wards have been around for quite a long time, but the tech-enabled virtual wards is quite a new thing. And that means that there's not much existing evidence to show how it should be done. And there's no real experts in tech-enabled virtual wards, apart from the people who are using it, and we're learning as we go along. So there's lots of unknowns, and there's very limited best practice on what's out there. A real challenge that I found, and it comes a lot into my role as the lead nurse for clinical engagement, is that we are changing our behaviour as clinicians. And I always use the analogy, as a nurse, if we change our behaviour, it's not an admin change. It's not a case of we're going to put some forms in a different place. It's a behaviour that has a consequence for a person on the end of that decision. And so I think quite rightly, as clinicians, we can be really cautious in how we change our behaviour. I think the ways that we go about that is building up clinical confidence in the technology and in the services. So it's not uncommon for me to go and sit next to a remote monitoring a client nurse who's new to the service, and I call it a psychological handhold essentially, and just say, yes, that's normal, that's what I've done, I would recommend doing this, this, or this, etc. And it's also just creating that cultural or professional change, and supporting clients to make that systematic change to make sure that it's safe. Because there's a lack of evidence, it then begs the question, how do we know that what we're doing is safe? So for example, if you have a new pathway and a patient submits a set of readings and they're out of threshold, is there a time limit for when we should respond to those red alerts? And this is something we've learned as we've gone along, and we do have time thresholds in there to make sure that we respond to specific pathways in the ways that we need to. That means that we don't know safe staffing and patient ratios, which also makes it difficult for capacity or workforce planning. The way that we've dealt with these issues is that we've started incredibly small. Obviously, as a private company, we want to have as many patients as possible on the service, but patient safety will always come first. So any clients that set up new services or any new pathways, we say start small, start with 1-2 patients that are easier and less complex patients. And that's your opportunity to find out if there's any gaps in the policies or procedures that you've already developed. What are the challenges for managing a remote monitoring team? So as anywhere in nursing, recruitment could be an issue. There are staffing source shortages, and then also obviously holding on to those clinicians as well. I think it's really important when we start advertising for those roles that we try as much as possible to have clear and concise job descriptions, which is difficult if it's a new role. But also to let new clinicians coming into the service that, yes, this is a new role, but it's also a really exciting opportunity to get stuck into something and to be able to mould that service into something that you are proud to deliver to patients. Because of that, it's really important to have effective remote leadership. And I think for any remote team, which I would imagine crosses lots of different disciplines and jobs, is that you make sure that there is a system of communication available. So even though people are remote, they're still able to get in touch with their colleagues, so that you're still able to have that bouncing ideas off of each other, which is really important. And not just having the system in place, but also the cultural expectation that it's okay for colleagues to get in touch with each other and ask each other questions. building that team of remote monitoring nurses, like any other team, it's incredibly important to have a mix of skill. Try as possible to have a robust induction to introduce those new people to the team. And where possible, hold team engagement days. So we have training days, usually every month, and we utilize specialist knowledge from either people in the team, or we can get an outsider to come in, and it just helps us make sure that we to have that social contact as well as learn together. And then with clinical governance, so one of the things for managing a virtual ward service is that that virtual ward often can be filling a gap between two other services. It could be that the referring service isn't necessarily the service that's looking after those patients. In that case, it's incredibly important to have really clear and defined clinical governance so that it's clear who takes responsibility of the patients at which moments. So for us, because we share clinical responsibility with some of our clients, we will have shared clinical governance, and we have set agendas with each where we go through just to make sure that we're covering everything that we need and that we're making the service as good as possible and as safe as possible. So what are the competencies needed for remote monitoring? And I know that communication skills is mentioned probably for most jobs that you're going to go for. You're going to say, I have good communication skills. I really want to emphasize how important it is in remote monitoring. You don't have any of the non-verbal communication happening when you're on the phone to a patient. And a lot of the consultations do take place over the phone. There is option for video consultation as well, but often you'll find it's mostly over the phone. So that means you need to be really good as a clinician for drawing out information from patients. You need to have very clear ideas of what assessment questions you need to ask to rule out your red flags or make a differential diagnosis. So you need to be able to ask those questions clearly. You also need to be able to have awareness of your tone, because we're not able to offer gestures or facial expressions to patients, and often they're ill, they need reassurance. So it's really important that you're able to get that through your tone on your voice on the phone. You're able to communicate that empathy, via your voice. You need basic technical skills because you're relying on technology to look after your patients. And I will say that one of the other core competencies of remote monitoring is just being able to work autonomously. We are always part of a team. There are clear escalation procedures, but ultimately you're at home with your patient and it's you that's responsible for making those decisions in that moment. It's really useful to have advanced clinical assessment. The clinicians that we've got that have come from ED, and I would say from my own experience as well, that my assessment skills from ED have been really important for looking after these patients. Any specialist knowledge is amazing. And as mentioned, we can't forget that these patients are at high risk of deteriorating depending what pathway they're on. So there always needs to be, you need to be able to deal with an emergency situation in the moment. Cross-functional competencies. So it's really good to have an idea of tech. It's really useful, particularly working in Doccla. We can make recommendations for any features that we want or find any shortcuts, etc. At the moment, we don't take clinical responsibility to the point where we're making prescribing decisions. However, I know that there are services out there where there are AMPs involved. And as said, remote monitoring is very much a nurse-led service. So there are AMPs involved in making those prescribing decisions. And then even further, as I've mentioned, the advanced clinical assessment, if you're able, particularly as AMP level, able to make those clinical decisions and clinical reasoning and assess risk, that's really, really useful for these services. So what are the challenges of being that remote monitoring nurse? It can be quite isolating, it can be very frustrating when you've got IT failure and you've got a patient that you're concerned about. Because it's a brand new, because it's quite a new role, is there access to training and development, or is this a career path that someone might want to go down? It's really difficult, or more difficult, to maintain bank staff competency. It's hard maintaining bank staff even when it's just on a face-to-face role, but remotely, that adds another layer of difficulty to that. And then we're task shifting some of our roles onto patients when they come onto a virtual ward service. So therefore, we need to maintain that patient engagement. What I will say is, generally speaking, patients are really happy to be at home. So that's not often always a challenge. It's often something that they're willing to engage in so that they can stay at home. The solutions that we have to some of the challenge, we are developing skill-specific training. So at Doccla, we have recently started doing phone skills training so that our clinicians do learn how to communicate over the phone, and that's been a really vital part of our training package. We do as per usual, we have the supervision and we have mentorship. We are developing a competency framework, and what's really exciting is I know that there's there's universities involved in developing competency frameworks and having remote monitoring modules. So I'll talk a little bit more about that on another slide, but that's quite an exciting idea for the future. And then also the team structure allows opportunities for career progression. When you do have your escalation points of call, it's really important to remember that clinical escalation is vital because it's obviously a patient service, but then we also need to have IT management on call as well, just in case there are any tech problems. And then having clear policies and procedures and making sure they're accessible so that clinicians can access them remotely is really useful to make sure that clinicians can work as per procedure during the day. So I think I've probably already built up quite a good idea of what makes a good remote monitoring nurse, but I'll summarize it here. So they absolutely have to be a good communicator, and they have to have high level of empathy and certainly of patience, because you can be on the phone for quite a while with patients supporting them to use the devices. So it's really important that you're someone that is empathetic and able to communicate really clearly. We are relying on clinicians to work remotely. They're not in front of us. So we need clinicians who are reliable and who are able to organize their own day. It's really important to document what they're doing because, again, it's not a face-to-face situation where clinicians can pick things up as they're walking around. We're relying on the notes written by other people. We need them to be responsive. And I think it's quite important in remote monitoring that not only are our clinicians self-motivated, but because a lot of these services are quite new, it's a real advantage that if the clinicians are motivator and able to lead other clinicians and share the vital learning that we've got, they need to be able to prioritize and work well under pressure. So the really nice thing, it used to be me that did these PowerPoints and it was my feedback, but because we've got a team, it's really lovely that we can get I can get some feedback from our clinicians. So this is actually feedback from the people who do the role with Doccla. So they say they've got more time to assess and care for patients. And I would imagine if you imagine you're on a ward and I walk down the corridor to a patient at the end, I'll get stopped 5 times before I get there. The nice thing with remote monitoring is when you're on the phone to the patient, you're on the phone to the patient and there's no other interruption. So you can really dedicate that time to them. It's really rewarding getting positive feedback from patients, and it's not uncommon for patients at the end of the time on the service to say, oh, I'm going to go buy a SATS probe, because they know what their SATs mean now. So it's really nice to know that we're providing some health education. It's an opportunity to really hone those assessment skills. And I think something else to note is that it's really nice to be able to tailor care that's actually really specific to the patient, because each patient's in their home, excuse me, which means they have access to their own unique resources. So you have to see each patient on an individual basis, and it can be really nice to include family that live there or to utilize any previous knowledge that they have, etc. So indirect benefits, it's an opportunity for a better work-life balance. I've said before on these presentations, I live in a studio, so my commute is 3 meters if I want to work from home. So I get more time in bed, which means I can be less fatigued and I've got more energy to care for patients. One could say it's more green because we're not commuting or using our cars. You could argue that there'll be less sick days and that you have a chance to focus on your workload. And then this is one of the penultimate slides of this presentation, and I really like to end on this slide because I think this is probably one of the most exciting points for myself. So this is a quote that I think is worthy of being said verbatim from one of the nurses in our team. So working as a remote monitoring nurse has allowed me to continue my nursing career despite having a long-term health condition / disability, which I am so grateful for. It has allowed me to still use my nursing skills, but in a different setting. So remote monitoring offers an opportunity for nurses who, for whatever reason, are no longer able to work in that physically demanding role, but still have an absolute wealth of experience that would be really useful for remote monitoring. So there is the potential there that we retain more staff in the nursing workforce. If we take that one step further, and this is where I mentioned about academics, about universities being involved. So when I was doing my nurse training, I remember being on painkillers at the end of some of my placements because my back hurt. It could also be that if you take that one step further, there's going to be lots of people that are physically unable to do the nurse training, but they're more than capable of making a clinical decision. So could we use remote monitoring as an opportunity to increase accessibility to the nursing workforce, where rather than people going down the traditional nursing path that aren't able to, they go down a specific remote monitoring path and become a remote monitoring nurse, or whatever we can choose to decide to call it. And that in itself would increase the nursing workforce and increase accessibility to the career. So in summary, I hope that I've conveyed the idea that remote monitoring offers a new and exciting career path. It absolutely requires a certain skill set, and I do think there's opportunity for career progression in there, and certainly opportunity for learning and honing certain skills. Remote monitoring is often nurse-led, so it's a real opportunity for nurses to inform and shape the way that we deliver the services that we want to deliver. And it's an opportunity for nurses to be forerunners in education and training and development. We are still very much learning, and what I know now is a lot more than what I knew 12 months ago, and I'm excited to see what I could know in 12 months' time. I think this is a really exciting area to be working in. And I'll just say thank you very much. That's my contact details, and please feel free to get in touch.
Wow. Thank you very much, Rebecca. That was amazing. You really brought to life what working in a virtual ward looks and feels like, but also touched on some really important issues, and we've had some really great stuff come through in the chat. Thank you, Gordon, for joining us back on screen. I'm going to try and do justice to all the questions in the chat and try and get as many of them answered as possible in the time we have allowed, because I think the discussion is always so important, isn't it? And I think we've seen that people really want to get into this. You've really given us some food for thought. And I'm going to start with a question that came from a number of sources, but Kate Pound kind of put it quite succinctly, saying, moving from early discharge to admission and attendance avoidance, stopping those ambulances, even getting to the ED, not just managing the front door. Currently, we're very focused on the back door. How might we, what is your vision, each of you, for how we move beyond pulling people out to keeping them at home in the first place? And I think I will go to Rebecca in the first place instance, because you're biggest on my screen at the moment.
Okay. Yeah, so I think we do have some services where we, for example, where we give kits to paramedics. So I think a really useful place to start is doing almost a mind map of what are the pathways for patients, and then look at what are the points of intervention. So is it a GP? Are there volunteers that go out? Could something be linked in with 111? Having a look at paramedics and really having a think about what's a sort of out of the box way where we could intervene as early as possible to stop those patients from going into hospital. And unfortunately, I don't think it's always a one size fits all. I do think it can be quite a local problem, but it just takes, just a couple of people to get together and have a look at mapping that out, the patient pathway out, and think, okay, at what points could we intervene to stop that patient from going in?
Thank you so much. And Gordon, building upon that answer, another question was really about how do we integrate across social, community, acute care? How do we cross those divides to bring the right care to the right person? So I guess you lead some of this on a strategic level. What's happening to enable those discussions, to do that sort of pathway mapping that Rebecca alluded to get to a design that brings this care much earlier in the patient pathway?
Really interesting, and I think Kate has raised a really good question. And I think that earlier this year, virtual ward program across England fell under the urgent and emergency care directorate within NHS England, and I think that's fantastic. And there's been big improvements in referral pathways and processes. So admission avoidance from ED point of view, assessment suite, ambulatory care, absolutely, just Rebecca said, discussions with our paramedics and our local ambulance services, as well as our community services, CRRT teams, urgent and emergency care from our hospital avoidance teams, district nursing teams, and primary care as well. So absolutely the emphasis needs to shift and move more towards that admission avoidance to stop our patients coming in. Because in my personal opinion, I do feel that, you know, the worst thing you could say to a patient is, you need to come into hospital. They don't want to do that. So if we can manage them outside safely and effectively, then absolutely we should do that. So I think Kate has raised that. I think it's so important to link all of the services together. And again, coming through some of the questions, that social support is so important. We can't just leave patients there who are unable to manage, and we need to make sure we integrate. So there's lots of discussions, and I'll give you an example in Newcastle with Newcastle City Council, local voluntary services as well, in relation to the support they've been given to patients who are at home. And we link very, very, very much into our community services and that huge nursing team, whether it's CRRT, hospital avoidance team, district nursing team, all of that, who have that expertise and that knowledge and know who to point in direction to and who to refer to when it comes to social care. It's so important.
Thank you ever so much. And another question building on a theme is the term virtual ward the right term, and is that inadvertently limiting our thinking in this space? Bit of a provocative one there, I guess.
I'm not sure whether virtual ward is the right term. I sort of agree with that. I think that people think that immediately gives the emphasis that it's all technology and it's a bit Star Trek-y and it's a bit, when actually hospital at home is a nice term, and it's a term we've used for a very long time. And I think sometimes it can get a bit lost because we also have long-term condition monitoring, remote monitoring, and we have lots of different terminology. And I think it would be good for us to look at that, take that out to the side and have an open discussion about what we think fits best, and more importantly, what will our patients understand?
Thank you, Gordon. And building on that, Rekha asked about what do we think about virtual hospices? So Rebecca, can you talk a bit more about the different sorts of pathways that you're currently managing, and then perhaps go on to how you think this might apply to something like a virtual hospice, and what would you think the challenges would be in providing a virtual hospice?
Yeah, I think that actually leads really nicely on from the question that was asked before in terms of, does virtual wards limit the sort of imagination we have of how this could work? And I would argue, I think, yes, it does a bit sometimes. This is definitely something that I've thought about in my time in virtual wards. And so, for example, I think the virtual ward definition is that we have a patient who would usually be in hospital and we're going to look after them at home. But I think there's opportunities for tech-enabled support in other areas, such as health education, such as managing chronic conditions and trying to reduce exacerbations, but then also absolutely in hospice care as well. I will hold my hand up and say that my area of expertise is not palliative. However, there has been discussions around, could tech-enabled virtual wards support, say, a person who is long-term palliative and has gone into hospital, could it support them to go home a bit earlier? Could it not just support the patient, but also be used to support the family as well and help them to care for the patient at home? So I absolutely do think that there is a space for tech-enabled support in those areas. Likely take someone with more experience than myself to come up to see where those gaps are, but yeah, I think it could be a space where it could be quite could be useful.
Thank you very much. And in terms of us then, our role, Gordon, I'll come to you because I know core to your role is growing this community of digital nurse leaders, isn't it? And you have a very sort of strategic overview of not just a service, but a region. What do you see our role in terms of designing new models of care, maybe the hospice or whatever it might be, but really pushing the boundaries for this so that it might become that career pathway that Rebecca described so beautifully in her presentation.
Absolutely. So you know that it's a very, very, very passionate about what we do for nurses. And as you well know, Natasha, because we worked with you for a very long time, is the most common question I get asked as a digital nurse is that my Wi-Fi isn't working. What do I need to do? We need to change that ethos. To be a digital nurse, you do not need to know how to take a laptop apart and put it back together again. You absolutely need your clinical skills to be applied in a digital environment. That's the vital thing. And so many nurses can do that. And it's that passion that's required to look at that pathway of care that's for that patient, that's the most effective, the safest way, and making sure that it's the patient is at the core of all of the things that we do, to looking at holistic care of the patient and how we take things forward, and training our nurses to question, reevaluate that plan of care, and not just translating a bit of paper onto an electronic form. That is not about digital nursing. It's about how are we bringing our patients forward for the patients who want to, and providing that, what I go back to, that pick and mix solution. Not all solutions will fit all patients, and we must be driven by what the patient wants, what they need, and how we can deliver the best and safest service that we can. This is where I think nurses come into the fore. They absolutely they know the patient pathways, they know their patients really, really well, and they're the ones that can be the advocate, which of course is our primary role, to make sure that our patients are involved in that discussion, in that process, that reevaluation, and how do we make sure that we're getting our patients ready for what they could be really beneficial for them and have better outcomes for them and give them more control over their healthcare.
Thank you very much, Gordon. And I guess building upon that is, so you mentioned in your presentation, Rebecca, about evaluation. And there's lots of questions in the chat about how we involve patients, but also how do we evaluate this, and how do we iterate and continuously improve the service that we're delivering. Can you tell us a little bit about that from the very practical way that you're doing it in Doccla? And then perhaps, Gordon, you might want to come back round on that and talk sort of more broadly about some of the work that you're involved in at a regional level.
Yeah, absolutely. So at Doccla, assessing patient feedback is part of our clinical governance. So we do send out surveys as part of our service, and they can send them back anonymously. And we do get such valuable feedback there on what are the pain points and what are the bits that the patients like. Generally speaking, we get really good feedback. And I do think one of those, one of the key areas that we're going to be aiming for is, are patients happy? Do patients like the service? It's become somewhat more difficult to assess things like, is it affecting the length of stay? And I will absolutely hold my hand up and say that's beyond the scope of what I can look into. However, the research side of me, in the past, I have done thematic analyses of patient testimonials. This was slightly earlier on in the days when we were a bit smaller and had fewer pathways, and we had some amazing feedback. And I do think that being able, if you have time and able to analyze that qualitative data just as much as the quantitative, it can also just add a certain richness to find out how a service is really performing. In terms of quantitative data, I think especially remote monitoring, it's growing into a field now where it needs expertise like data analyses, etc. You can come in and do a more robust and valid job of assessing that data.
Thank you, Rebecca. And before I come back to Gordon to sort of expand on that, just give us some examples. I'm curious about what your patients say about the care that they receive. Have you got any examples for us?
Yeah, so I think a key theme that comes through is that I found really interesting as well, actually, is that patients feel like they have more communication with their clinician when they're on the virtual ward than. So I think a quote that won't be verbatim was, "I've spoken more to you in the last couple of weeks than I have in my GP in the last year." And this was a patient with a chronic condition. they report feeling safe. And I think that that is a mixture of the clinician that's providing that care, as well as the clinician utilising the features that are available in the technology, because we can use technology to communicate with the patients without clinicians having to actually call them. So patients report feeling safe, they report feeling that they've been supported, and they also report feeling that they've actually learned about their health as a consequence of being on the service, which I think as clinicians, where we want to try and make our patients be able to manage their conditions as best as possible, it's really nice feedback to hear that we've managed to provide some learning for them.
Thank you so much. And Gordon, so from a regional level, how are you evaluating, and how is the region deciding where to invest?
So our patient feedback is incredibly vital, and there's been a huge amount of work from a national, regional and local level been done. I think some of the most stark stuff that we've seen was during COVID and the feedback we got from patients. And go back to what Rebecca said, patients feeling safe is one of the key things. That patients, they need to be able to feel safe at home, that they can speak to someone if they have a problem or issue, that someone can deal with that. So there's a lot of things that we're looking at minimum data sets and the qualitative side in relation to how we're grasping this stuff back. How do we improve the service? How do we make sure the patients are out there, their long-term outcomes are good, that they're not getting any side effects or any other implications or anything from being at home, that they're not having, that they're feeling well, and that we're getting the service right for them. But one of the key things I think that sometimes we often miss is that we also need that absolute anecdotal information and feedback that clinical staff get from their patients. We need to capture that too, because sometimes when we give a patient a questionnaire, they either won't fill it in, or they'll fill it in thinking, oh, because I really liked the nurse and I really liked the doctor, so I'm going to give them, even though they weren't feeling comfortable with it. We need that clinical feedback, not only from what clinicians believe how the virtual ward's going, but what is that anecdotal feedback they get, that trust that a patient has in a nurse. They'll tell them if they're having problems with the technology, or they don't like it, or they're not sleeping, or I'd prefer to be in hospital. That's the stuff we must capture as well.
Thank you. And I'm mindful that we've only got 20 minutes left, and there is a wealth of great questions here, and I'm trying to theme them, and I think we should probably slightly shift theme, because I suspect we've got a lot of nurses here who are thinking about, you know what, that sounds like a really interesting job, and maybe it's the job for me, based on the questions that I'm seeing here. So there's a lot of questions in here about how do you develop your staff, and where are these education opportunities that I can access? Do either of you have any advice or insights into what's available that you could direct some of these individuals to? Who shall I come to first? You're nodding frantically, Gordon, so I'm going to come to you.
Yeah, absolutely. So my first piece of advice would always be, find out what's going on in your local trust or where you work in your primary care. What digital programs going, because there absolutely will be. Do not think for a second that because you've got no digital experience that you cannot be involved. Clinical skills, as I've already said, are the vital part to any digital program that's going out there. You must make sure that our patients are safe, and having that clinical skills and knowledge for application is so, so important. So my first piece of advice would be, get out there and find out what's happening and be involved. Try to get involved in some sort of way in any digital program that's out there. It could be on an advisory panel. It could be part of the program team. It could be anything at all. And do a bit of your homework, do a bit of the research, find out where else it's happening, get some exposure. To me, that's the first sort of thing. The next level then is looking at specifically digital information, like the Digital Academy, looking at Florence Nightingale Foundation, the Digital Scholarship, which I undertook. There's multiple conferences and education programs, and some of them are specific around nursing as well, which I have to say really good. Chime is one of them. Look at their syllabus, look at what courses there are available, speak to your manager and have discussions in relation to getting some other places where you can get some more digital education and seeing what's available in your local university. And the final thing is look at what's happening in your region and in and around you? What's happening in the trust next door? Is there a digital nurse there? Is there a digital nurse in a nursing group? So in the Northeast in Yorkshire, we have a regional CNIO group, but there's multiple digital. We've got a shared decision-making council for digital. These things are all going on in all of the regions across England. It's about, sometimes it's just, I understand it's not easy to find them. So your local CNIOs, your regional CNIOs, your digital leads across that will all know this information. Send them an email, give them a call, drop them a text, whatever, and start to get involved in some of those. What's happening next door? What's happening in the region? What's happening across the country?
Thank you, Gordon. And Rebecca, I'm going to come to you on that question. And as well as talking about the competencies that you're looking for, what you've learned, and you alluded to some of that, of what people need to do the specific role of being a remote monitoring clinician. There's another question in the chat about student nurses, and you also talked about we could reimagine education, couldn't we, and create a whole new career pathway. So views on creating student nurse placements in services like yours.
Yeah, absolutely. So that's, again, it's quite an exciting area, really. I absolutely think that, well, I know that there are universities that are considering remote monitoring as placements for student nurses, and I think it'd be an excellent opportunity, because if we think about where things are going to go in the future, this is how virtual wards look at the moment. But I can say from conferences that I've been to, the technology that's out there is incredible. And it's just going to be another 2, 3, 4 years before that amazing technology is available for our patients. So I think it's a really good time to get students involved in the technology and the remote monitoring, because then when it comes in 10 years time, when everything, when things look very different, they're going to be the experts. They're going to be the ones that have sort of grown their nursing career around this technology. In terms of getting into the virtual ward space, Gordon's just mentioned some incredible opportunities there, which I will say that I wasn't aware of. So that's amazing that he's put that out there. I think for my personal experience is just about having the attitude of being open to change. I think we can, and understandably as clinicians, we can be quite reluctant to change our behaviour, and because we know we like to stick with what's safe. But the virtual ward space is really changing that. It's changing how we provide that care. So a focus on what competencies are needed for remote monitoring, a focus on learning those assessment skills, with alongside an attitude of being able to say, but we could do it this way. Could we use this technology to help, etc. And keeping an eye out for those opportunities will absolutely help get into the virtual ward space.
Thank you ever so much, Rebecca. And then there's some sort of, I'm going to bring us to some sort of technical questions. So some really sort of focused and specific questions. Interoperability, integration with EPRs. Rebecca, your system, how integrated is it, and how easy is it for people to make sure that they can view their EPR, and more importantly that the things are speaking in a two-way approach, so that you have the right information at the right time to look after that patient?
Yeah, so we have a team of a tech team that focus purely on integration. So we integrate with numerous EHRs, and we have open APIs, and it's really vital that is available, because it really supports a more holistic approach to looking after patients. Because as the nurse doing the remote monitoring, you will have access to that data on the dashboard, and you might make your notes on the EHR. You can also make your notes on the dashboard, and it gets sent through. But then it might be, if you do need to escalate to a GP who might not have access to the dashboard, you're able to say all of their readings are on the EHR. So it supports that communication to the wider MDT. In terms of how integration at the moment, we can integrate where we can send readings and notes, any information from the dashboard through to the EHR. But this is a really fast moving place, and we have clients with different requirements. So we have a team that we can just dedicate to the next integration requirement. So it's very much a fast moving area of the service.
That's an interesting part about anything, whether it be remote monitoring or whatever part of digitally enabled service delivery you're involved in healthcare at the moment is trying to keep pace, isn't it? Because the tech moves faster perhaps than sometimes our willingness to change our approach to clinical practice.
Yeah, absolutely.
And a really basic question from Tracy Viney, who says, apologies if I missed this, do you provide 24-hour real-time monitoring?
We don't at the moment, but it's client driven. So I would say in the future, it will end up being something that we do.
And something that was quite interesting that was mentioned, and I want to commend it to people, was Mercy's virtual hospital. I think that was Kate Pound, again, who said you should take a look at this, because I guess that's talking about a whole hub approach, isn't it? You looked quite panicked there when I said that, Rebecca.
Sorry, it's because I just realised. Sorry, it's because I realised I answered the previous question wrong, that I might have misunderstood. So I'm sorry, I didn't hear that question. But in terms of the 24 real-time monitoring, we do continuous monitoring, if that's what that question was referring to. If it's referring to clinicians being on the dashboard at the moment, it's daytime, but it will go to night shifts as well. And because of that panic, I didn't hear the second question. Could you please repeat?
So thank you for the point of clarity. The vital signs are captured in a 24-hour period, but you have a clinical team that isn't quite 24 hours yet, but may become so in the future.
Absolutely,
and I guess I made the connection to the next question there in this way that my brain works of drawing bigger and patterns out in the world, is this idea that we will move to many more ways that we can monitor people remotely and support them and bring the right expertise to the right people in wherever they are, at home or somewhere close to home rather than in hospital. And it was commended to us in the chat that we look at Mercy Hospital in the US, which is a whole virtual hospital. So I know I'm going to go and have a good look at that, because I'm really curious about building much bigger hubs where we coalesce expertise, because you've described real clinical expertise that's required in this space to do this really, really well. So I think that'll be really worth a look. So thank you, Kate, for mentioning that. And as I say, do go and have a look, people. We are almost out of time. So I am going to just do a quick scan, if you'll bear with me, folks, to make sure that there isn't anything that's coming in the last couple of minutes that I need to pick up. If not, I'm going to do a quick summing up and give everybody that vital loo break, because we never ever manage to factor that in our virtual day or in our real actual physical ward day as nurses, do we? So I think we should do some self-care too. Yes, so an interesting observation from Deborah. Wouldn't it be really interesting to see how we could develop our own simulated virtual ward to prepare students for this type of career? Yes, absolutely. I work as an associate professor at Salford. They, with many other universities, are doing some amazing sim education and creating we've got a whole sim, a virtual community online where nurses are being trained alongside police officers and others, where they can engage in a whole person's pathway. So yes, Deborah, you're right. We need to do loads more of this, and all this starts with education, from the student placements through to some of this stuff. We called out really loud and strong for that in the Phillips Ives review, which is due to be published soon. I hope to see HEIs moving in that direction much earlier, but it sounds like there are some emergent ones already, so go looking for those. In summing up, I guess what I've really taken from this conversation is we start with quite with this term virtual ward, and think about pulling people out to give them do some vital signs at the end of their care journey in the hospital, because they think, we probably need to do a view and make sure they're just a bit safe. And what we've talked about now is actually moving way beyond that. And what it really struck me was when I started my training many, many moons ago, back in 1995, I remember being an eager beaver student nurse, where it wasn't long before the Blair government came to power, and we were really talking about care in community closer to home. This fitted with our nursing philosophy of ensuring people can have holistic care that really supports them to live their best lives, paying attention to all their ADLs. And I watched with despair over the years as we've stayed resolutely hospital focused, and that part of the care economy has had less attention. I think tech is a game changer here, which sounds like, you know, a paradox. It sounds like it shouldn't be so, but tech could be a game changer to getting much more person-centric and allowing people to stay home. So I'm really excited to see where this is going to go in the future. And you said it, Rebecca, this is nurse-led care. So we have a real responsibility and opportunity as a profession to redefine what we do and grasp, perhaps have a bit of a renaissance of what nursing practice is, and really be in relationship with our patients, even if that is with a headset that you are wearing very beautifully there, Rebecca. So yeah, I hope others have come away with new thoughts, new insights, a bit inspired, ready to go away and do a bit more research. I think our panel are open to being approached with further questions, and I know their contact details were in the slide, so I hope you pick them up. Do go away, talk about this, spread the word, and get others to come have a look. And as I say, do reach out to myself. My contact details are also in the pack, but I'm Natasha at futurenurse.uk, or any members of our panel if you want to know more about what's been discussed today. And good luck with all your endeavours in the remote care sphere, as I guess the fact that you've joined means you are interested in experimenting and are perhaps already doing something in this space. Thank you very much, everyone, and goodbye. And I've literally given you 1 minute for a wee. I apologise. Goodbye.